Well, hello, everyone, and welcome to this live and recorded event for the International Myeloma Foundation, who is celebrating our 35th anniversary this year. This is the IMWG Conference Series, the International Myeloma Working Group Conference Series, whereby we review some of the great data that has just been presented that I'll share with you in a moment from actually 3 separate meetings that we've just had. And so it is absolutely my pleasure to be your host as we go through this over the next 90 minutes together. Joining me today is Dr. Beth Feynman, who is a nurse practitioner at the Cleveland Clinic, Dr. Sagar Lonial, who is at Emory and also serves both on our scientific advisory board and on our board of directors of the International Myeloma Foundation. Unfortunately, Dr. Mariví Mateos, last minute, is not able to join us from Spain, but I've asked Dr. Lonial to channel his inner Spanish investigator. So if any questions come in Spanish, then I will defer to you, Sagar, to answer those. So Dr. Mateos sends her regrets that she can't join us, but we know that we'll engage her in the near future. And then, as noted here, I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation, Joe McHale. We'd like to, right off the start, thank our sponsors, AbbVie, Johnson & Johnson, Regeneron, and Sanofi for their kind support in this educational endeavor. Although there's going to be a lot of talking, and sadly, you're going to have to hear my voice quite a bit. I'm sure there's therapy for that, but for as much as you'll have to hear my voice, you will have the privilege of hearing the lovely voices of Drs. Feynman and Lonial. But we want to hear from you as well. We want you to be able to submit your questions. I'll just quickly remind you that there is a Q&A button that you can submit a question, and we will do our utmost to get to as many of the questions as possible towards the end of the program. But also note that we keep track of all the questions that come to the IMF. For those of you who are subscribed to our multiple social media channels, which includes Facebook, Instagram, LinkedIn in particular, and of course we catalog them all on our YouTube channel. We do everything we can to try and answer everyone's questions. We have a hashtag that you can drop at any of those social media outlets of Ask the IMF, and we'll do our very best. As some of you know, I do dedicated videos just to answer questions, and we'll do our very best to get to them tonight or at a future event in the coming weeks. We also want to hear your feedback. We learn a lot from you as to how long these should be and issues that relate to this program. Today's program is at a slightly advanced level for patients who are very familiar with myeloma, although of course it's open to everyone. And in particular, many of our community oncologists, this is their chance to get their full dose of myeloma after these big medical meetings. And we will be doing another one at a more patient-friendly level in the future, but please give us your feedback. We're very interested in hearing more from you about that. Also, this is, of course, being recorded. So if you are not familiar with the really incredible number of videos that we have at the IMF, then please go to myeloma.org. This is a capture of that homepage under publications and videos. You can see all the different publications that we have that you can order them in print or just have them electronic. And indeed, we have all sorts of videos that outline multiple events, including this IMWG Conference Series there that you see second in line under IMF videos. And we would be more than happy to share those with you so that you can learn more about myeloma. All right, let's start to dive in to what happened. This is a tale of 3 meetings and perhaps a tale of 2 cities, as it were, because 2 of these meetings were in the same city. So we had ASCO, the American Society of Clinical Oncology in Chicago, right at the end of May and the first few days of June. And this is a massive meeting, actually biggest cancer meeting in the world, 45,000 people attended. Then secondly, we had the International Myeloma Working Group Summit, which occurred in Milano, Italy. I should say it was pretty hot, Milan. I described the convention center like a hot yoga studio, but it was quite warm. But in our summit, we had nice air-conditioned room, thankfully, and we had close to 200 individuals present, including a little over 120 IMWG members, along with many of our guests, to really discuss what is the state of the art aren't in multiple myeloma. And in fact, as you see through this presentation, as we go through the topics that we've selected, you'll see some of the commentary that came out of that meeting. And then lastly, just ending literally 48 hours ago, was the European Hematology, or EHA, annual Congress, also in Milan, Italy. Here we had approximately 18,000 individuals that attended this meeting. So it's going to be impossible for us to cover all that was in myeloma. Of course, at ASCO, it's all cancers that are covered. At EHA, it's all hematology that's covered. But we will do our best. And what we've decided to do is to to outline these 7 topics that we're going to go through today. Number one, more than ever has there been discussion around screening for myeloma. Then we'll talk about smoldering myeloma, for which we're very grateful that Dr. Loniel is here. He's really considered one of the world experts in the field, having led trials in the area. Thirdly, we'll talk about the evolving and changing world of frontline therapy, where we have really moved to remarkable new approaches frontline that have improved outcomes in the long term. Sadly, we know myeloma typically will relapse, and so we'll have some discussion of some abstracts in the early relapse and then late relapse setting. Don't miss this. If I were only allowed to present a couple of slides today, they would be in that late relapse session, but don't fear, we will get to them, and there are many great abstracts in every section. And then we'll have a few minutes to talk about the new definition of high-risk multiple myeloma, which was just published in the Journal of Clinical Oncology last week and was discussed at length at our IMWG Summit. And then briefly, we'll talk about how the IMWG does have subcommittees for various topics. And I'm going to ask Sagar and Beth if they have any key takeaways that they heard from each of those subcommittees. So that's our outline. That's our objective for the next 85 minutes or so. So make sure you've got some liquid near you and a comfortable chair, a notepad or an iPad, and let's dive in. So let's start with screening for multiple myeloma. We had really actually an extraordinary lecture looking at the biology of what goes into myeloma becoming myeloma. I don't need to remind this crowd that all myeloma is preceded by smoldering myeloma, and smoldering myeloma is preceded by MGUS, or monoclonal gammopathy of undetermined significance. There's some really fascinating work trying to understand how do people develop myeloma to begin with. As we all know, we don't know the real cause of myeloma in the vast majority of patients, as it were. There are some things associated with it, unfortunately, like Agent Orange and certain chemicals and individuals who have been first responders, firefighters in particular. But for the vast majority of patients, we don't know. And so I just included this slide because I was fascinated, and I get to see in a few minutes what the experts here with me think. Is for each of these sections, I'm the appetizer, and then they will be the main dish in the discussion. It seems that some of the things, some of those chromosomal changes, some of those early biological events happen actually quite early in our lives. Even though we think of myeloma as typically being a disease that happens later in life, the average age of diagnosis is approximately 69. It's younger in African American and Latino American patients. But there's some interesting work hearing where some of that mutational burden started even in our 30s, if not younger than that. And secondly, there was some further discussion of the famous iStop study. So the iStop study, known as Iceland Screens, Treats, or Prevents Multiple Myeloma, for which the IMF was very heavily involved, was this unbelievably massive study of over 80,000 participants, over half of the island of Iceland, in individuals over the age of 40 consented to have a blood test to determine if they might have MGUS, and then specifically to see if that screening process and the follow-up from that screening process may ultimately save lives. Is it worth screening? We screen now for a few cancers like breast cancer, like colon cancer, and it took years to make that determination. And we are hearing from our colleagues in Iceland that they think that within the next 2 years, we may have an answer as to whether or not this intervention ultimately would save lives. And there was quite a bit of discussion of this. I won't go through the details of it, but patients who did develop MGUS were then randomized to either not being followed up as per guidelines, or followed up even more intensely. So for section one, a couple of my comments. This iStop study was massive. And I think really critical for us to understand if ultimately we might be screening. We also saw, biologically speaking, that some of these events that lead to multiple myeloma may start at a very young age. And when we look at screening in general, let's say colon cancer, it's based on your age, it's based on gender, it's based on family history. My father sadly died of colon cancer, so I had to have my colonoscopy starting at a younger age. I actually have one coming up in a few weeks. And I wonder if it'll be the same in myeloma. Will we be doing it differently in men versus women? If someone's of African descent versus not of African descent? That's the kind of questions I get to hear from the experts here in a moment. And our friends at the iStop trial say to us they may have that answer. So Sagar, maybe start with you, because you've been involved in some of the basic science of this and the work in the past. When you hear screening for myeloma, what do you think our next step is going to be? Do you think we're going in that vein or not?
Yeah, I mean, I think the iStop study is going to be really important to help us make that determination. I think from a practical perspective, the incidence of plasma cell disorders is far less frequent than breast cancer, colon cancer, or even lung cancer among smokers. So I don't know that it's going to be a universal recommendation for everybody. But I do think that there are pockets of patients who might benefit, particularly first-degree relatives of patients that have myeloma. I think in that sense, it makes a little bit of sense. I think particularly in Black patients that have a first-degree family member, I think there the sense is even higher. So unfortunately, the iStop study won't address that second question. And one of the struggles that I have, again, with that iStop study, which is quite comprehensive and is pretty massive, is that it really doesn't have anybody other than white Northern Europeans in the study. So I think we'll learn something about who may benefit from early screening, but I think, quite honestly, the definitive answer is going to come from studies that we do in the US or that come from Africa, specifically looking at the incidence in large populations and whether screening is justified.
Oh, I think those comments are very well taken. Thankfully, there is actually, in fact, our colleagues and the IMF is a sponsor and a supporter of the CHAMP study, which is a screening study in the Charlotte region, where we're beginning to test the feasibility of screening within the African American population. And actually, just yesterday, Sagar, I got a request from our colleagues in Africa about the potential of doing a screening study in one of the larger countries there. Beth, from your perspective, obviously you have multiple perspectives, and we're so thankful that you've joined us here today in your role as a nurse practitioner, but also a myeloma researcher and an editor of a prominent journal. What's your take on screening? Do you think Sagar and I are making sense here?
Yeah, absolutely. And again, thank you so much for having me at this time. Screening is difficult because we know mutational burden will start in the people in their 30s. But so committing them to a lifelong routine screening every 6 months, every 12 months, every 3 months in some cases, and the cost of care will increase. I like that the iStop study is assessing the psychological burden as well as whether or not it'll make a difference. But to Dr. Loneal's point, it's just a Northern European population, and it's not representative of the U.S. culture, the U.S. population. So we did a small screening study in our general area. It was about 100 patients in the Cleveland area, and about the incidence was about 4 to 6%, but we really targeted the African American and diverse population. Still did not find a lot of those that needed to be treated with myeloma, but we did have a couple that were smoldering, and so I think that there will be more data that comes out of this. But right now I'm just recommending first-degree relatives to let their primary care providers know that they have a first-degree relative with a diagnosis of a blood cancer, and really heightened awareness, educating the primary care providers to have a heightened awareness as well, internal medicine, nurse practitioners, physician assistants, those will touch base with patients, and then hopefully we'll have more data that comes out from future studies.
Yeah, no, thanks, Beth. I mean, I think you've highlighted two really important things. One, as Sagar had noted as well, when it comes to the actual screening, that's going to take a little bit of time for us to really figure out if that can happen. But in the interim, we should be very alert to testing for myeloma in the primary care world. This is actually one of the major arms of our Empower program, and I don't mean to be a commercial for Empower, but let me put a little quick commercial in. We're doing a Juneteenth event later this week in New York City, where we have recognized that one of the disparities in myeloma is related to the delay in diagnosis. And some of that delay has to do with access to primary care, with the overlapping feature of diabetes, so many other things. And so I think it was great how you reminded us that, in those patients that may have anemia, may have back pain that's out of keeping, may have, or bone pain for that matter, that's out of keeping with usual bone pain. In individuals with renal insufficiency that it has not been determined the nature of it, that we should be thinking about myeloma. And when we think about myeloma, we not only order a serum protein electrophoresis, but a serum free light chain assay as well, because that's not really screening per se as much as testing for, as opposed to screening a healthy population. But until we're ready to screen, I think we have to double down our efforts on testing those individuals who may have multiple myeloma. So more of that to come in the future. Well, on the subject of screening, part of the concept of screening is to catch myeloma early. We know that myeloma presents itself as smoldering myeloma, and there has been a lot of work, and this is a couple of slides from the discussion at our IMWG Summit on the 2220 model, which I'll remind people means that someone has either greater than 20% plasma cells in their marrow, the M spike is greater than or equal to 2 grams per deciliter, and the free light chain ratio of the involved over uninvolved light chains are greater than 20. And someone can have either 0 of those, 1 of those, or both of 2 of those, or all 3. And if someone has 2 or 3 of those, we've historically considered them to be in that high-risk category. So we're talking about high-risk smoldering myeloma now, not just high-risk myeloma. That'll be a discussion later. But in that spectrum, we have MGUS at one extreme, smoldering myeloma in the middle. There's a large spectrum. And we all know that these definitions are not perfect, and there are multiple ways of doing it, but this has been one of the models that has been proposed. And this is partly because of the really cataclysmic study that we had in December presented at the American Society of Hematology meeting that we discussed at our post-conference series back in December, where we saw a clinical trial that randomized patients to either get daratumumab monotherapy for 3 years or just be monitored quite closely with annual PET scans, marrows every 2 years, labs done every 3 months, found that at the 5-year mark, 63% of people in the daratumumab arm still had not progressed, whereas only 40% in the observation arm. And so if we look at them adding to that criteria, as I've just noted, you see the difference in what happens in those two groups, that active monitoring, the median time progression understandably is about 2 years, but had not yet been reached with daratumumab. And so the discussion at the IMWG was, well, we actually now have multiple options for high-risk smoldering myeloma. We may early intervene with daratumumab, as was just, and I know, Sagar, you just came from clinic. I just came from clinic where I had this long discussion with a patient who came in literally with the reprint of the Aquila study, asking me if they should go on to daratumumab. But we need to obviously closely follow up these patients. Sometimes that may be enough. But as I'll come to you in a moment, Sagar led a study using lenalidomide as monotherapy in these individuals. And of course, there are multiple trials ongoing. And so it's still an area, if you will, of equipoise, where there isn't a simple answer that every patient would go to. And it really underscores the importance of that discussion, that shared decision-making, as we think about this, as we continue to do more studies in the field. So my quick take on smoldering is that I really do think this Aquila trial was critical. It helped us prove not so much that we're preventing myeloma, but we really are delaying that progression. And in the right patient, so in the conversation I had with my patient today, I can tell you he's 83 years old, and he said, if this kicks the can down the road and I never have to have myeloma, he said, I'm still golfing 4 times a week here in Scottsdale. I want to be able to do that. I'm not too keen on going on to full therapy, but I feel like we need to do something. And that person, it was the best thing to go with single agent. And so that discussion is important, but there are other options. And as I've noted, there's some trials coming. So Sagar, I'll turn to you first, because this is really an area of your expertise. What's your take on the current state of the union for smoldering?
Yeah, I mean, I think having survived ODAC, I think it was really important for us to finally have something that we hope will be FDA approved so that patients can have this as a potential option. When I see a patient with high-risk smoldering, and I think that's the first comment to make, is we really do need to make sure that risk stratification is happening, because patients with low risk or no risk smoldering, I think that's a very different discussion than it is somebody with high risk or intermediate risk.
Agreed.
And using 2220 or using the Aquila criteria, there was a lot of talk at ODAC about, is this the right criteria? Do we have the right definitions? The reality is that the control arm in Aquila really demonstrated that, the median time to progression for the control arm was somewhere between 2 and 3 years, which fits into that group of high-risk smoldering patients. I think that having potentially DARA as an option, I still encourage patients to go on a clinical trial, and we've got 2 clinical trials open, trying to understand whether more intensive therapy offers them benefit or not. And finally, the third point that I'll make is about understanding the patient's mindset when they come in. The first thing I do when I see a new patient with intermediate or high-risk smoldering is ask them, are you the kind of patient who, when you know there's something there and we're not doing anything, it drives you crazy? And if the answer to that is yes, then I'm going to lean much more towards, well, these are the options and this is what we can think about. But there is a not inconsequential number of patients who say, I know that there's something there, but as good as your prediction methods are, there's a chance I may be fine in a couple of years, and I want to ride out that be fine for as long as I can until I actually absolutely need therapy. And hearing that from a patient drives me towards a different approach with that patient as well. So I think taking into the account their thought, their perspective, and then providing the right data on which options are best for them really is the optimal solution.
And maybe, Sagar, I can just follow up with one question on that. And I know, of course, Maddie V is not with us tonight. She led really maybe the first very large study using lenalidomide, and then you, of course, led another lenalidomide study. Now that Aquila is here, let's assume that it is approved, and obviously lenalidomide may not be formally approved in that context, but typically can be accessed. What is your view of daratumumab monotherapy versus lenalidomide? Is there a certain patient population you'd lean to one or the other? Is it you just sort of discuss the differences between going on 1 year versus 3 years, or the side effect profile? I mean, how do you approach that discussion?
Yeah, I mean, I think if you're going to be on label, then DARA really is the only other option. I know that some people have used LEN in the NCCN guidelines. I think it's category 2. And so I prefer LEN over LENDEX. But when it comes down to a pill versus a subcutaneous injection, that's a patient-related discussion. I don't know that there's necessarily criteria that drive to one versus the other.
Gotcha. Beth, what is your take on this high-risk smoldering world here? I know that this is an area of interest of yours as well.
Yeah, absolutely. I think that Dr. Loniel had an excellent point in that he described the process of shared decision-making, taking into account the patient's preferences, the clinical data results, and then having that discussion to what's best for that patient. The Aquila study had a little bit more loose definition, I think, in my opinion, with the difference in free light chain ratio of who qualified for that study. I like the Mayo 2220 when we have the discussion about whether or not to treat smoldering, but again, clinical trials have gotten us to where we are, and we can't go any further unless we continue on those clinical trials. So we do have some more innovative clinical trials. We also have the Deter MM which is a national trial that's available at many institutions, and you might have a patient in your backyard that would qualify for that. So just ask the patient, if they're interested in a clinical trial. And so well-designed clinical trial is my first go-to, and then we have the discussion about to treat or not to treat, and that's still the question, in my opinion.
Yeah, that's beautifully said. I think that maybe the only last point I would add is, as good as a risk stratification we have, we know that there's no perfect method. And what I also always encourage our clinicians as well is, there's sort of the absolute number, but then there's also the change in that number. So if I use the analogy of, sadly, someone with high-risk smoldering myeloma is running towards a cliff, and you want to catch them before they fall off the cliff, there's not just the distance to the cliff, but how fast they're running. Sometimes we see people who say, well, I meet this criteria, but your M spike has gone up from 1.2 to 3.2 over the last 6 months or year. I think this may invoke us to actually fully treat. So these are dynamic models, and I know we're looking at trying to capture that even more, but before too long. So great discussion.
But I think one important point to make is, and this is a nice nuance, when I see a patient with smoldering, the first thing I do is bring them back in 8 to 12 weeks to get a sense for what's happening to that protein. That one you just described that went from 1.2 to 3.1, I don't know that a prevention strategy is really the right answer for that patient. That patient likely already has myeloma, and so you'd pick that up by seeing the data in 3 months and say, I really think you're going to get to myeloma quicker, and I don't know that a single agent is really going to be the answer for you. So the subtlety in that process is not lost.
Yeah, completely agree. So that discussion I had with that patient about the 1.2 to 3.1, we decided to go to full therapy because that person is getting so close to the edge of slim crab, they're running towards it, but that they absolutely needed full therapy. Absolutely. Well said. So let's turn to frontline therapy. I mean, this has just been incredible. I feel badly I couldn't include all the great studies that were here, but I've picked a few of them. The first is the MIDAS study. And I know this looks complicated, but let's just walk through this for a minute, because this may be one of the most important discussions we'll have today, which is do we interpret the results of this in a certain way or not? And so what they decided to do here was to give induction therapy with isatuximab, carfilzomib, lenalidomide, and dexamethasone, or KRD, kyprolis, Revlimid, dexamethasone. And after 6 cycles, patients were either MRD negative or MRD positive. If you were MRD negative, you were then randomized to just get more of ISA-KRD or have a transplant added to some ISA-KRD. If you were MRD positive, you got a more intense treatment with either a transplant and ISA-KRD, so similar to the arm above, or even more intensely with a transplant. I won't go through all of the numbers here, but I will go immediately to their takeaway points, which was those patients that were already MRD negative, it did not appear, just from a depth of response and MRD negativity, that the transplant added more to what they had achieved. Interestingly, in the MRD positive patients, the tandem or 2 transplants back to back didn't seem to have any more benefit than a single transplant. So we're going to come back to this because that could have huge implications. I think the other study that was particularly influential that has really changed our practice in general is the Perseus trial. So you may remember the Perseus trial was where we added daratumumab to the historical VRD before the transplant as consolidation. And then interestingly here, where we had more updates was in the maintenance setting, where patients received 2 years of daratumumab and lenalidomide, or up to 2 years, depending on their MRD status, and then thereafter would just continue on daratumumab, or if they were continue on Revlimid, or if they were MRD positive, they would continue on the doublet. So this is really important because we're in the significant number of patients getting longer dual maintenance. And again, I'll come back to you in a moment, Sagar, because I know your center has really led the world in thinking about dual maintenance therapy. And in that group that had the dual maintenance in the 4-drug arm, remarkably here on the right, we have over half of them not only achieving MRD negativity, but staying in there for over 2 years. which is really quite remarkable. Furthermore, Dr. Moreau had noted that in that DVRD arm, there were only 11 patients, or 3% of patients, that progressed within the first 18 months, as opposed to 7% or 24 patients in the VRD arm. And so this was really emphasizing the benefit of that quadruplet. And then lastly, the GMMG concept trial was, I included it because I thought it was a fascinating design of looking at patients that have high-risk multiple myelomas. We're not talking about high-risk smoldering anymore. We're talking about true high-risk myeloma. That this was about as aggressive therapies we've seen: ESA-KRD, a transplant, and then continuous ESA-KR, or then consolidation with ESA-KRD, and then continuous ESA-KR. And what struck me about this study was that if you look to the right, that the 6-year overall survival rate is still over 2/3, which is some of the best outcomes we've seen with high-risk myeloma in a patient population that historically had a significantly inferior outcome, more recently getting better, but not catching up to the great outcomes where we're expecting a median overall survival of over 10 years in the standard risk population. What was fascinating about that group, too, is those who achieved MRD negativity, no surprise, did so much better than those that did not achieve MRD negativity. So yet another study looking at the potential power of MRD, or the value of MRD when treating our patients. There were some other studies that for time's sake today we won't get into, but there was interesting bringing belantamab mafodotin, which will almost definitely make its way back to clinic, and we'll discuss it in the relapse setting, but was being brought in a frontline setting. And similarly, the bispecific antibodies that we now use in heavily relapsed setting, in particular elranatamab, had an interesting trial, the Magnetism 6 trial. We got an update in patients who are not eligible for transplant in combination with daratumumab and lenalidomide. So a couple of comments about frontline. I mean, we've really seen quadruplets in many patients become the standard of care, although I'll be interested to see what the group thinks, and in particular with the dual maintenance after transplant, getting patients to sustained MRD negativity. I think we all believe that MRD is going to help guide therapy. Whether or not it's too early to say that we would stop doing transplants in patients that have achieved MRD negativity. And I actually asked that question at the ASCO meeting, and the authors said, well, we're not quite ready to stop doing that yet. We need more follow-up and see how long the MRD is sustained. But nonetheless, I think it means that MRD is going to guide our therapy more. High-risk smoldering, or high-risk myeloma, remains a challenging area, but with MRD as a goal, we can have better outcomes. I didn't get a chance to go through all the studies, but it's fascinating to me how many are using carfilzomib in frontline therapy now, and I think we're going to see more of that. We saw that in the MIDAS study, and as I noted, other options in the future are belantamab and bispecifics. So Beth, maybe I'll start with you this time, and then we'll come to Sagar in a moment. You know, it keeps your head spinning with all these new studies and follow-up studies. What was your take home in the frontline world?
Yeah, absolutely. I think one of the first things I do when I see a study is I look at, is it a well-designed study? Is it randomized? Is it phase 1, 2, or 3? And then I try to soak up the results. These studies are so complex. We saw the MIDAS studies, the Europeans pronounce it MIDAS, I guess. I heard that a lot in Milan, but the MIDAS study was very well designed and suggests that we don't need 2 transplants anymore, but in US, we weren't doing a second transplant for many people. So that kind of helped answer that question. But it doesn't answer the question of, if you achieve MRD negativity, do you even need to go to transplant? We have so many new innovative therapies. So what I'm recommending to my patients in the frontline setting, we all start with 4 drugs, depending on the age and frailty and performance status, if they're not in a clinical trial. And then we have the discussion, you know, transplant is not going away anytime soon, but if it's really not something you want to do now, let's assess your bone marrow after 4-6 cycles. Let's assess your MRD negative status and have the discussion. Do you just want to de-escalate and stay on therapy based on some of the other study designs? And so I can't wait for the future to find out if ESA-KRD is going to be better than dara-VRD and ongoing trials. Again, if you have a patient with newly diagnosed myeloma, seek out a clinical trial, because now we have CAR-T in the front line, randomization trials. We didn't even go over here. And so I'll stop talking and hear what Dr. Loniel has to say, but really exciting stuff.
Sagar, I know that you've got an interesting take on this.
Yeah, I mean, I think I agree with Beth, the idea that we don't do a lot of tandems anymore, and so I think the relative benefit in that context is pretty limited. What I'll say is that I think, to me, the questions are really a couple. The first is, what is the optimal time to assess MRD to make a therapeutic decision? And during the IMWG, the point I was making was, early MRD, which I think is within the first 9 months, is really most useful for escalation of therapy. I'm not convinced it's useful for de-escalation of therapy, particularly in a trial like MIDAS, where the highest proportion of patients that achieved early MRD and were randomized to de-escalation were the high-risk patients. And we know those patients achieve a deep response, but they don't stay in a deep response. So I'm really worried about what the PFS is going to look like in that, particularly for the 414s or the other high risk. So, what I end up telling patients is, if you look at the projected PFS for Perseus, which is Dara-RVD with transplant, versus projected PFS for Cepheus, which was Dara-RVD with no transplant, the PFS is double for the transplant. And we're continuing to encourage people to have the transplant because it really does so much more for that first PFS. And for many patients, they may never need second-line therapy. They may have other comorbidities that may get in the way and not myeloma, and you've maximized their duration of first remission. I think the second point is, if you're going to take that strategy of, well, let's see how deep the response is, remember in the first cohort of MIDAS, they had trouble collecting stem cells after 6 cycles of therapy. So you need to commit to that collection within the first 3 to 4 cycles of therapy, and perhaps take 2 more if you're going to let MRD drive that decision. Now, again, I'm not in favor of that, but certainly many patients and many providers are having those discussions. I want to make sure patients always have the best options available, and if you're going to go down that road, make sure you've collected your cells in advance.
Yeah, I know. Such excellent points. I really do worry about people prematurely looking at this and saying, okay, you're MRD negative, you don't need to go to a transplant. And I love the way how you couch that escalation versus de-escalation. The paradox here is that those high-risk patients, sometimes even more of them initially get into MRD, but then they can't sustain it. We've seen that since the days of the Arkansas early trials, right? That high-risk patients typically actually have a better response, as it were, but then they relapse more quickly. And so that sustained MRD negativity becomes important, because I'm sure all of you face this. I know we face this at the IMF regularly, people calling in saying, it's kind of like, I want MRD or bust. And it's too simplistic of you to think that one measure of MRD negativity, especially early on, will make such a prolific impact. But we'll see. As Beth mentioned, trials are ongoing. I mean, I can't believe we're doing a talk on Frontline. I don't even have time to talk about whether or not CAR T will be there, but that data is not mature yet. So that's a bit of a commercial for our next IMWG Conference Series, when we look at other things like bispecifics and CAR Ts up front.
So Joe, 2 quick points that I'll make before you get to early relapse are, you're right, there is this almost obsession with achieving MRD negativity, and patients that don't achieve MRD at day 100 are depressed. And quite honestly, I've got clinics full of people that never achieved CR, and 8 and 9 years later, they're still wherever they were, with a very small M protein on lenalidomide maintenance, doing fine. So I think it's important that we not oversell the relative downsides of not achieving MRD. It needs to be looked at in the context of, what is the risk? What is the treatment they're on? How stable is their low-level disease? Those are all factors that I think need to play into guiding a patient on whether not achieving MRD negativity is a win, or if it's a loss, or if it's just neutral. And we need more time to really appreciate what that means. And the flip side of that is, we just finished analyzing our KPD maintenance for high-risk patients. And a lot of those patients didn't achieve MRD negativity until 1 year or 18 months into maintenance therapy. And KPD in that trial had a median PFS of 65 months for high-risk myeloma. 65 months. That's not the answer. I'm not telling you we're done, but I'm telling you the idea that, you know, you need to do all of these crazy things to get people MRD. Sometimes you got to have the wisdom and the guidance to be patient and see where things go.
Well, thank you for those.
If I could just chime in, that's an excellent point, because there are, I think it's in some studies, about a third of patients that never achieve MRD negative status. And I have patients that have never been on maintenance after stem cell transplant prior to 2010 that are still trucking along with an M protein of 0.30. And so, again, taking that MRD recommendation with a grain of salt is I think, very wise recommendation.
And I think it follows the biology. We have some patients who, even I remember Dr. Barloghi used to say this, you know, people go back to MGUS. It's almost like they've got this residual bit of disease. As I said at the MRD meeting in Miami, that little bit of MRD that's left, sometimes it's Bambi and sometimes it's Rambo. And we don't really know often which one it is. There's one we want to eliminate, one that we don't have to. So thank you both for those additional comments. All right, we're going to keep rolling here because the questions are streaming in. Let me just remind our audience, feel free to submit questions. We're going to do a rapid fire Q&A after we complete these 7 sections. We're a little past halfway into our sections here, so we'll be good for time. So let's go to early relapse. We've said, sadly, that most patients with myeloma do relapse. This was the Heraclea study. So I included this because not so much the results, if you will, of the clinical trial with respect to efficacy, but this was a new way of delivering isatuximab. The 2 CD38s we have now, daratumumab and isatuximab, are typically given subcutaneously for daratumumab, but intravenously for isatuximab. And so in this study, they've introduced something new they call the on-body delivery injector, the on-body injector, OBI. And I've had a chance to work with this. It's a rather small little device that gets soft taped to the skin of the patient, and you push a button. There's no interaction with needles. Beth, I'll be interested in your take on this in a few minutes from a nursing standpoint, that the nurse actually doesn't have to handle the needle. It's a tiny 30-gauge needle that administers the drug over about 12 to 13 minutes on average, and then can be removed later. And in this study, they did show that patients preferred the subcutaneous approach, that it seemed to show the same level of efficacy and pharmacokinetics that we see with the IV from a non-inferiority, at least, analysis. Patients, as I noted, were more satisfied with getting it than receiving it IV, and they didn't see any sort of safety signal that would prevent us from doing it. I also add, because this is going to be particularly relevant over the coming months, is the DREAM-7 study, where belantamab was studied as a triplet versus triplet, which we don't often see, especially in relapse disease. Here with belantamab bortezomib dex versus daratumumab bortezomib dex, and we had updates in the DREAM-7 study where we saw really considerable differences between these two, with a median progression-free survival of essentially 3 years or 36 months in the belantamab, bortezomib, and dex arm, which was now updated here based on high-risk cytogenetics. And we see really quite a bit of a difference, but still a very impressive 21-month progression-free survival in those patients that had one or more high-risk cytogenetic feature. And I'll be interested in your take on this in a minute, Sagar, of course, because you have been so sentinel to the work. You know, it seems that every time we get to every section, I keep saying, well, Sagar has been sentinel to the work to this. I mean, it's no surprise, as I'm sure all of our audience knows, that just last week we had the privilege of honoring Dr. Loniel at the International Myeloma Working Group Summit with the Lifetime Achievement Award, the Bob Kyle Award, for all that he's done in multiple myeloma. And I think this seminar tonight is showing to us, Sagar, that you've been involved at every step along the way in myeloma. And so we of course, appreciate you immensely for that. And then I also wanted to include some follow-up to the CARTITUDE-4 study. I see a couple of questions have come in asking about this study. For those who don't remember, this is the study of comparing single CAR T-cell therapy in the form of cilta-cel or Carvykti compared to the standard triplets. And here they just had further follow-up looking at whether someone was one prior line of therapy, and even in patients that had extramedullary disease. And it seems that every way they cut the data here, we continue to see the benefit of a CAR T over a triplet. For time's sake, I didn't show slides from it, but I will mention that what may well be one of the next drugs approved in multiple myeloma would be linvoseltamab. We've already seen it approved in different countries around the world, which is another BCMA-directed bispecific antibody. And they had some interesting studies here, the linker study combining it with carfilzomib, MM2. There was also another study of adding it to bortezomib. So we're starting to see more combination therapies with these bispecific antibodies to further amplify their effect. So my take is that, one, the on-body injector, I think it's a novel way of delivering this. It's a little bit more challenging in the US system, but this could potentially someday be delivered at home, make it easier for patients to be at home. We all believe the belantamab Bela is back and will almost definitely be available in triplet combinations in the near future. We're also seeing that already approved around the world. I do wonder where it's going to fit. Is it going to be initially for patients who are not eligible for CAR T or do not have access to CAR T? And I'll come to our guests here to get their input on that. And then lastly, as I mentioned, I think there will be interesting data with more bispecific antibodies entering the field. But why don't I start with you, Beth, to comment particularly on the on-body injector, and then I'll come to you, Sagar, to comment on belantamab. So Beth, what do you think about this OBI? Is this something that's going to benefit our patients?
I'm actually very excited about the OBI for isatuximab. The Heraclea trial and several other trials suggested that there's an increase in patient satisfaction. And keep in mind, the Heraclea trial was modeled after ISA-POMD from the ICARIA study, and it showed about the 71% or something response rate. So similar response rates, but I think the satisfaction was there. And so I saw a question that was coming through the chat. Are you measuring quality of life, patient-reported outcomes in these studies that we're describing? And the answer is yes. And so I'm looking forward to this as well, because it's a very small gauge needle. It's a 30 gauge needle, which is super tiny, like a diabetic needle, compared to some of the other drugs we have out there. And so I think from a patient standpoint and then a nursing standpoint, this is something that I'm really looking forward to having another therapeutic option for our patients. So imagine they come in and they get their shot and they can take the pills at home versus getting hooked up to an IV to get the anti-CD38 monoclonal antibody. So more to come.
Absolutely. Sagar, your take on, I mean, obviously you know these studies like the back of your hand, the Dream 7 and Dream 8 studies. What do you think about belantamab and its resurgence?
Yeah, no, I think those are both really exciting studies in the context of bringing BCMA-directed therapy earlier in the disease course. I think we've learned a lot about how to give Bela. I think we've understood that the dose and schedule can be variable based on what a patient specifically experiences. I think we also know that I think it's 4 weeks or 5 weeks, we'll be back at ODAC trying to wave the flag to get Bela back on the formularies once again. And I think different from last time, the push to try and keep people on that every 3-week schedule just isn't there. If a patient can, that's great, but if they can't, they'll do just as well. And I think that is an important point for all of us who either receive this or give this treatment, to recognize that you don't have to sort of push to MTD in order to make this work. It's okay to use a less frequent dosing schedule if that's what the patient's symptoms are really telling you. And you pointed out the whisker plots, particularly focusing on high-risk disease. What I'll tell you that's quite interesting, I told you about our KPD high-risk maintenance. Ajay Nook at our place wrote a study using Belapom Dex for high risk, and we've been using that now for a couple of years. And the data just looks amazing. And so the idea of BCMA-directed therapy, particularly a drug that doesn't need to be given quite as often as maintenance in partnership with a pill like pomalidomide, those kinds of options, I think, are raising the bar for our patients at every level.
Yeah, I think that that's such a critical point that I want to emphasize is that, again, a little bit like we had in the earlier discussion of smoldering, choice is always going to be good for our patients because something are going to resonate. Just like you said, Sagar, when that person comes in, are you the kind of person that's okay letting, the therapy not touch you now, or the one who really needs to get something done right away? I mean, I think similarly here we have choices of going to CAR T, going, to something that's less frequent. And I think you said it well. The precedent is set. There is not a single drug in myeloma, I would argue, that we use now the way it was first introduced. There's that fascinating paper that Dr. Raj Kumar, the chair of our board, was a senior author on. Xavier Leloup was the first author of saying, do we really always have to think about maximum tolerated dose? Maybe we should be thinking about minimally effective dose. But, we use so many drugs now differently than when they first came out in terms of their dosing and frequency. And we're using Bella in our clinic for most patients every 8 to 12 weeks. And I really have found some of our patients, it's just remarkable. They literally have to come in every 3 months. And so more to come, as you said. But let's move on to a later relapse. And I can't help but answer the question from Sherry. Hi, Sherry. It's always good to have you on these calls. And I know we'll get to lots of questions later, but she asked, what is the difference between early relapse and late relapse? There's no concrete line, but generally speaking, when we say early relapse, we don't mean it happened early or quickly per se. We think of it as patients that have had about 1 to 3 prior lines. So the second, third, and sometimes fourth line of therapy that they've had, we typically think of early relapse. Late relapse now, we're going to be thinking about those patients that have had even more relapses. And again, I don't want to play favorites here, but if we only had 8 minutes to do this seminar tonight and we could only talk about one abstract, I might be tempted to talk about this one. This was the long-term follow-up of the CARTITUDE-1 trial. So these were patients who were given a single dose of cilta-cel or Carvykti, and who on average had about 6 prior lines of therapy. So these are, if you will, rather sick patients, very advanced. We would have expected them to perhaps live no more than a year. And here we found that 33% of them are still completely disease-free at 5 years. So 1 in 3 patients is still getting nada, my favorite therapy, nothing, 5 years after that single infusion of cilta-cel. Really quite impressive results from this study. And this turned out to be a very much discussed study. Even in the New York Times, there was an article about this study that was presented by Dr. Peter Voorhees at ASCO. But there was also a fascinating study that was presented both at ASCO and EHA. And at EHA, it was the plenary discussion that Dr. Popat presented, which was the first time we've seen this trispecific molecule. So for our crowd, I'm sure you know this, but bispecific drugs, they're called bi because essentially they have 2 arms. One arm hooks onto the myeloma, another arm hooks onto a T cell and engages it. And we've had bispecific antibodies approved that hook onto BCMA, that hook onto GPRC5D. But we've not yet seen a drug like this that hooks onto both BCMA and GPRC5D on the myeloma cell, as well as the CD3 arm on the T cell. And what was quite fascinating here is looking at different cohorts, and perhaps the numbers aren't massive yet, but still impressive that we have a remarkable response rate, in particular those who were BCMA and GPRC5D naive, with essentially everybody having a response, and the vast majority of them achieving VGPR, and over 2/3 of them getting into CR or greater. And perhaps what was even more striking to me was that we saw significantly less of the GPRC5D side effects that we can often see with talquetamab, the changes in taste, the weight loss, the nail and skin-related phenomena. I think a lot of that, of course, I'll see what the two of you think, had to do with the less frequent dosing of this drug, where patients are getting this drug about once a month. I think while we're on the subject of trispecifics, I should mention the other trispecific that we got an update on. We'd seen it already at the previous meeting, but the bispecific that was presented from our colleagues in Australia that now adheres to BCMA and CD38 as opposed to GPRC5D on the myeloma cell, and still the CD3 on the T cell. Again, the numbers are still relatively small, but the cohorts are lining up and you're seeing a consistent response rate, even in those patients with higher risk disease, those who have been on prior things like CAR T, and patients with extramedullary disease. And so they have now established a dose for this, and with a median half-life of 17 days, we can expect that this drug can be given significantly less frequently as well. And then lastly, which was just presented 48 hours ago as the late breaking abstract, or one of the late breaking abstracts at EHA, Shaji Kumar, who sits on our scientific advisory board at from Mayo Clinic, presented the study of the combination of talquetamab and teclistamab, specifically looking in those patients with extramedullary disease, and seeing that Tal-Tec combination still supported a response rate of about 80% when compared to in monotherapy, roughly half of that in the low 40 percentiles. And then lastly, for the relapse setting, I can't help but make comment of another CAR T that is coming, anito-cel. And there was a lot of excitement about this study. It was initially presented back in December, and now with an update, and Gurbaksh Kaur presented this work, where we see this remarkable response rate of 97%, with, again, over 2/3 of patients achieving a complete remission or greater. And importantly, seeing, at least at this stage, obviously we need more time, but with progression-free survival of 80% at 1 year, and 95% overall survival at 1 year. And perhaps, and again, I don't want to draw conclusions too quickly, but it does seem that we have fewer of the neurological effects that we have perhaps seen with the other CAR T, or with cilta-cel, where we have not yet seen at least any of those more worrisome late effects. So lots to comment here on late relapse. I'll be quick so I can get Sagar and Beth's take on this, but very exciting data from CARTITUDE-1. I mean, there was more talk about how we define cure than ever before. Not saying that we're curing myeloma, but to start to see that fraction of patients compared to history is really quite impressive. Also saw this trispecific, which may hit that sweet spot of enough efficacy, but less toxicity by giving the drug less regularly, along with another trispecific, as I've noted. And we're seeing in a historically very challenging area, extramedullary disease, that perhaps this combination, by trying to go after myeloma in the hard to find locations, may be particularly beneficial. And now with the form of anito-cel, we have a new CAR T, not yet available to us, but quite likely in the near future. Sagar, so much to put in here, but what do you think, my friend?
Well, I think the CARTITUDE-1 data was certainly very encouraging and exciting. Stay tuned for the editorial, which will be life-changing. I can commit to that. I'm kidding. It'll be an interesting discussion around what cure means in myeloma, which I think is rapidly becoming an important distinction. I think even in the response criteria update, we're going to have a definition, a provisional definition of what it means to be cured, so we can begin to create a benchmark for future trials and for reporting down the road. I think what I'm most encouraged by in a lot of the data that you demonstrated was the idea of trying to use combinations of therapy, whether it's trispecifics that are internally combined or whether it's combinations like we saw in Redirect. I think those really do represent important steps for us to eliminate resistant clones. I think the idea of sort of flogging a dead horse until it's no longer functional, it just doesn't make sense anymore. And I think, to me, the variable that I think is going to be really important to augment the efficacy of these combined immune approaches is going to be drugs like the CELMoDs, where you're going to be able to reactivate exhausted T cells, perhaps make more T cells or NK cells that are going to make these drugs even more effective. And so questions around sequencing, not do I give BCMA before GPRC5D, but how do I give both of them in a way that doesn't exhaust immune function and still allows you to maximize benefit as measured by response rate and duration. Those are really going to be the scientific challenges for us in the near future, because What I think I'm more hopeful about is, you see all these genome jockeys showing you all the complexity of myeloma, and you get depressed with your head spinning, thinking that nobody can do well because the genetics is so complicated. And yet we see median PFSs of 6, 8, 10, 12 years for some of these trials, which tells me that immune therapy can get around some of those genetic aberrations. And we just have to be really smart about those combinations to be successful.
Yeah, I think you've highlighted that so nicely. I was sharing today in our clinic, Beth, with the amazing nurse practitioner that I have the privilege of working with, Susie. This notion that historically in myeloma, and Sagar, you couched it nicely in T cell function. I always say if you could create a T cell spa, then you're going to do really well in myeloma. But historically, if I give drug A and I get this much of PFS, and then I give drug B and I get that much PFS. I think historically in myeloma, we've proven that if you do A and B together, often you'll go longer than you would have gone with each individually. And so we're seeing that with the trispecific, we're definitely getting as deep, if not deeper, response. But I want to make sure that's sustained, because it would be great if we can not have to give someone a single bispecific, kind of, if you will, exhaust their T cells, need to give them a big break and then go to another. That maybe if we're doing these internal combinations, if you described, or external combinations, we might hit that Goldilocks sweet spot where we're able to maintain the activity of the T cell for longer without flogging it too heavily, so that we can get a better outcome for patients. So I know that's a bit theoretical, but I really do think that could be something that we'll see. So Beth, what's your take on all of this? I know there's a lot here, of course, but what's your take on this?
Well, I'm very excited to see that about a third of the patients who reported in the CARTITUDE-1 study that had been heavily pretreated, lots of prior therapies, are still MRD negative. Again, maybe those are the patients that went back to MGUS, but then the clone really isn't detected. Who knows? But I'm thrilled to see that, and to know that now we are redefining cure off of therapy for 5 years. Is that really a cure in myeloma? So that's the first point. The second point is the trispecifics are super exciting. I know that we have the Tech-Tel study at my institution, and 1+1 does not necessarily mean less side effects, but the trispecific, so you have the GPRC5D, skin, nail, oral toxicities, and then the teclistamab, the BCMA, infection types of worries. It almost looks like combining the molecule with the trispecific might have more on tumor and less off target effects. And so I'm super excited to see that data mature. And the anito-cel, I love Carvykti, I love CAR-T, and I love the options that we have also with the ide-cel as well. But to see the response rates in the anito-cel and the less concerning long-term neurotoxicities we are not observing in this study so far. So again, this is just such an exciting time in myeloma, and many of us have been doing this for a long time, and this seemed to be like science fiction, and now we just continue to have this embarrassment of riches. And so finding out about the sequencing, do you need to keep somebody on teclistamab every 2 weeks for 16 months, or can you go less often? And so those are the questions, those real world questions, that I think the real world data will be really important to see at ASH and other meetings.
Completely agree. I really do think that so often, I think it's one way that I've summarized a lot of what we're doing recently in bispecifics is less is more. Very often when we give them at the right dose, a little bit like Sagar said earlier about belantamab, we give it less frequently, then we hit that sweet spot where you have enough of the efficacy, but yet, considerably less toxicity. All right.
Make one more super quick point. I'm a really big fan of belantamab for the point that there's no CRS, there's no pre-medication. If you can figure out the right way to give it, it's actually a very easy drug to give in partnership with another drug. I think will be the way to go. Not everybody can take a bispecific or a CAR-T. These are hard therapies on many people. So if you can partner, if you're a community person who's listening out there, if you can partner with an institution and get comfortable to give these drugs in your clinic, I think the communication is really critical here with these drugs, and the patients are very sick, but you can give these and learn how to give them yourself, and then hopefully it'll translate to more options for patients in your area.
Oh, I completely agree. I think in these future episodes of this, as we learn more and more about it, I think we're going to start to see a lot more influx into the community of these drugs. But just for time's sake today, I haven't had a chance to talk about some of the new molecules. I think of etentamig, for example, as a drug, where right off the start, it's a bispecific that's given every 4 weeks. I mean, I think there's going to be a lot more feasibility of the use of these drugs in the near future. Well, our last two sections are a little bit shorter, and then we can dive into all the questions that have come. But I wanted to show this new definition of high-risk multiple myeloma. It may seem pretty complicated at first to those who aren't as familiar with this. We'll have this discussion today and again with patients in a couple of weeks' time. But a couple of things. It's really down to these 5 different things. One, that someone has that deletion 17p that's at least in 20% of the cells that are counted. Patients can have a mutation in that p53 gene. There can be a biallelic deletion of the 1p arm. They can have a beta-2 microglobulin that's over 5.5 while having a normal creatinine, because as we know, patients with a high creatinine are inevitably going to have a high beta-2 microglobulin. And then lastly, a little bit more complicated, but having at least 2 of the following, either the one of the translocations, the gain or an amplification of 1q, or a monallelic deletion, as opposed to the biallelic deletion that we saw as one of the 5 major factors of 1p. So this was discussed. Obviously, I'll get your take on it in just a moment. But this going forward was really, is really well presented by Gilles Corr to tell us that this was really trying to identify that 20% of patients with high-risk myeloma, the most high risk, in particular in that and newly diagnosed population. And we're hoping that this is going to allow us to focus some trials explicitly in that, although we've had trials, of course, before in the high-risk population. And that although not everyone has the technology to look for things like the mutations in TP53, but most of this is available by means of FISH as well. My take here is this is still a challenging area, although I heard, Sagar, you share earlier about the work that you've been doing with high-risk patients with KPD and Bela-POMD. There have been so many different ways to define high risk, and there's no one that's perfect, but here at least I think we've narrowed the focus to that more high risk. High risk loses its value if, you have definitions that capture 40-50% of all patients, then it's not really high risk. And that ultimately, even within high risk, there's a stratification of that sort of uber or ultra high risk that we may have to look at a little bit differently. I don't know, Sagar, what's your take on this? Because I know you've been involved with this process as well.
Yeah, I mean, I think the first message is I personally don't trust outside genetics. Because I think the way a sample gets to an outside lab is not always optimal. The way that they test for things, I mean, I still see reports where they're not doing CD138 selected FISH or they're not doing SIG FISH. And so it's basically a false negative, which I think is a huge mistake. And so if I see them early enough, I'm going to repeat a marrow just because I need that genetics to define what I'm going to do as maintenance. And it's such a critical part. We talked in the induction therapy setting about whether carfilzomib is making a resurgence. Personally, we give everybody DARA VRD as their induction. Where we really make our difference is in the maintenance phase. And we will often use carfilzomib as part of a high-risk maintenance strategy. So I think having that first set of data accurate, believable, and correct is really critically important. And a lot of times, unless you're at a major academic center or myeloma center, you're not going to get the right test run. And that's probably even going to get more complicated now that we're adding in p53 mutations as another measure of what it means to be high risk. You can do that. I feel more confident in a NGS-based approach than I do in a FISH-based approach. But there are panels now that will give you translocations, a gene panel, as well as deletions. And so you can get what we are historically getting from FISH using an NGS panel at 2 or 3 different centers. So seek out those centers to be able to optimally get the right information for patients.
Yeah, you make such a good point, is that on the one hand, we want the best definition possible. On the other hand, we want to make sure it's accessible, because if it can only be done in a few centers, then it's a challenging definition. Beth, what do you think about this?
I think there are a couple of things. For high-risk myeloma, it is very challenging, especially with one presents with plasma cell leukemia, extramedullary disease. And so if you're in the community, it makes perfect sense to try to give everybody 4 drugs, but also try to get that, as Dr. Loniel had mentioned, that first good bone marrow biopsy. And if you don't have the ability to do so at your institution, it's okay to partner with the community, with an academic center. And we do repeat marrows as well to get that information. We also will offer patients sequential marrows, but outside the context of a clinical trial. I say it's nice to know, but not need to know information. I won't make any decisions of stopping or escalating or de-escalating therapy oftentimes outside of clinical trials, because we just don't know if it really makes a difference unless they are really high-risk disease. But having that information might help us in the future to determine what the best therapy for that patient is. But it's definitely, those ultra high-risk patients remain very, very challenging. Those that relapse quickly, get into remission quickly, those are the ones that will need combinations and sequential therapies with the cell mods, BCMA therapies, as well as the GPRC5D as an innovative approaches.
That's excellent. No, I completely agree. I think it's also a chance for me to give a bit of a shout out to our amazing support groups that we have across the country. You can go to myeloma.org and learn about our support groups. And I mention this because we actually have a dedicated high-risk myeloma support group. That Becky Bosley works with us at the IMF, an incredible nurse, a wonderful person. A shout out to you, Becky, and the great work that you're doing in that group. And this will obviously be a hot topic of discussion in that support group in the near future, to better understand what's happening. I will maybe just leave one positive note here too, is that although, yes, we are tightening this definition and we do have these patients with high-risk disease, it has been remarkable to me at how many patients, even if I know Sagar doesn't always trust the outside genetics, but patients who have historically been considered high risk have done really well with some of these immune therapies. Like, I found it interesting when you look at that 33% of people that had disease-free after the Carditude, after cilta-cel given to them in the Carditude 1 trial, risk status didn't seem to be as influential in deciding who was in that group or not. Burden of disease in the marrow was a bit of an influencer, but, I hope to see a day where we can, have such great therapies that the distinction between standard and high risk becomes less significant or less important. And then lastly, I'll just put a comment that, and there's so much we could say here, but we are trying to look at myeloma at every single way possible. And our audience may not know that we have these different committees that look at every aspect of myeloma. Smoldering, you've had a lot of discussion about. Immune therapy is particularly exciting these days, but I wanted to give a shout out to our quality of life committee, the newest of the committees that we have, to recognize, as we always say, we don't treat myeloma, we treat people. And it's so important that we look at that, and it's trying to influence ensuring that in our clinical trials, we capture these measures, that we think about patient-reported outcomes, that we come to understand the value of this, that now that people are living so much longer with myeloma, we want to live well with myeloma. There was some great discussion in our bone disease committee and even in our sort of diagnostic committee looking at MRD and looking at things like mass spectrometry, where we can define this disease much better. And I think we've already had a bit of a discussion today around MRD, but there's so much more to do, I think, in the near future as it guides our therapy all the more. So with that, a couple of major takeaways. I'd be interested in hearing from Sagar and Beth about things that they take away. And then for our last 15 minutes, we're literally going to do the speed round for the roughly 100 questions we received. Now, there's no way we're going to get through them all, but we'll try and get through as many as we can. I mean, a few key takeaways from me: that frontline therapy has really evolved. I think we're really using quadruplets in the majority of our patients, along with continued CD38 antibody and lenalidomide in the maintenance setting or in the frontline setting for transplant ineligible patients. MRD is likely going to be more and more incorporated. It may result in the less use of transplant, but as we've described before, I'm not sure we're quite ready to pull that trigger yet. CAR T-cell therapy has really continued to demonstrate its prominence in late relapse, showing this 33% of patients disease-free. I'm excited to see what is going to be happening in the earlier relapse setting, because I suspect that the outcomes will be even better. And we have so much coming: antibody drug conjugates, new bispecific antibodies, trispecific antibodies, new CAR T-cell therapies. I mean, it really is remarkable what's happening. I know I could speak for both Sagar and Beth. We've been in this community for over 20 years, and I'm not sure I've ever seen a time quite as exciting it is now. But final takeaways before we go to the Q&A. Start with you, Beth.
The future is so bright, I've got to wear shades. I don't even know what else to say. There's just so much wonderful information out here. If I have one word of wisdom, it would be try to, if you are in the community, I said this before, I'll say it again, partner with an academic center. There's access to clinical trials. There's sharing of information. You can't possibly know everything as a community provider that you want to know, because you have to do everything else. And so sharing those patients is important. I'm really interested in survivorship in multiple myeloma, so I'm developing a survivorship program for our post-CAR T and transplant patients. We're actively getting them seen routinely so they can go back to the community, get treated in the community, but then there's this partnership in case of relapse or in times of distress if you need that help. So I'm going to stop talking so we can get to the questions. Dr. Loniel, to you.
No, that's great. The only comment I'm going to make to yours, Beth, though, is to remind people that we have really been trying to even be more clear about who the IMWG members are, where the experts are across the country. And you can go to myeloma.org or even just imwg.org, and you can see geographically where all the IMWG members are. So if you're not sure, who the experts might be in your area, and I can't speak for every IMWG member, but they tend to be very accessible. They want to help out in the community. So if you want to reach out to them or just call us at the IMF, and we'll connect you to experts in your area.
And don't forget about Milo, the chatbot.
Oh, absolutely. You can always 24/7 visit Milo, our chatbot, and he, she, they will provide you the information you need. Sagar, final thoughts before we go to Q&A?
Yeah, I mean, I think I think Beth really summarized it nicely. The 2 points that I would make is I think it's important as we talk about what to do in certain clinical contexts, that you make sure that those decisions are guided by real evidence, as opposed to, well, I don't believe that, or I don't think that's the right answer. There's real data out there. We have tons of phase 3 trials telling us what good options are for people. And so when a patient comes to me and says, well, that sounds pretty intense, my answer is, well, I have this data, and then this is our group clinical practice, and I don't have an answer for that, but this is our rationale for why we're doing what we're doing. It's not I believe or I don't believe this. So make sure you're using evidence to make those decisions. And second is, our goal with every new development is not to be as good as we were 5 years ago. It's to be substantially better. And so when you hear people say, well, you don't need a transplant, you could do just as good, to me, that means you're giving up. And I don't like to give up. I want to do better. And so as we think about where do all these treatments fit, the question is does this give me the potential to do better than I would have done 5 years ago? And those are unique opportunities that I think we're all fortunate to be a part of, because we do have so many new tools in the box.
Fantastic. Wow. Well said, both of you. I shudder to add anything to that. Well said, both of you. I'll just remind people that we do have upcoming webinars. On July 1st, we'll do one with a group of our wonderful patients. So we've entitled it The Patient Perspective. And then, as you know, a part of our ongoing workshops we do through the year, many of them we do geographically in cities, and then we do some virtual. And so we'll be doing a virtual community workshop. I'll be joined by these wonderful people that you see on the screen here, including Drs. Leip and Dr. Lin, who will be joining us for a community workshop. And then, of course, you can watch the replay of this, but I want to jump to our questions as we come back to the questions that have been provided here. So here we go. Let's just try and rifle through some of these in our last 12 minutes. How would you view CAR T-cell therapy as a second-line relapse after quad induction followed by transplant and maintenance therapy? Quick, Sagar, who are you taking to CAR T at first relapse?
Yeah, I mean, I think definitely people with functional high risk. So early relapse, relapse within 3, sometimes 4 years, depending upon how you want to define functional high risk. I think those are easy ones. Patients that develop 17p deletion at the time of early relapse. And even if you didn't, I will often have a discussion with a patient about, do you want to be on likely a DARA-based combination, or do you want to take your shot at CAR T-cell now? I don't think we know the answer to that, and I don't think we know necessarily the difference in adverse events between early versus late early relapse CAR T, meaning second line or third line or later than that. But I think those are discussions that I'm having with patients.
Yeah, I agree. I think we can be using it a lot more. Beth, does lenalidomide cause diarrhea?
In most of the early studies, 17 to 24 months was the onset of diarrhea. Diet plays a role as well. So looking at one's diet, adding in probiotics. There is lactose in the Revlimid capsules still, I think. And so keeping in mind whether or not you're lactose intolerant and just really adjusting your diet. We use a lot of cholestyramine. There were several studies that looked at cholestyramine, which is a bile acid sequestrant. It's a powder, easy to take, that can help mitigate the diarrhea. Meet with nutrition, keep a food diary, and yes, it can cause diarrhea, but not in everyone.
Yeah, and sometimes we obviously need to dose reduce or even dose continue. But a great question from you, Carl. Jackie, I hope we answered your question about translocation 414, that indeed by itself, translocation 414 is not now considered a high-risk criteria, but in conjunction with those others, as we noticed, it would be. I've just started on teclistamab, for which I know the median duration of efficacy is 11 months. What's new on combinations that might give longer control? And what's new on the reduction of frequency depending on the depth of response obtained? Maybe I'll just quickly answer you, Norma, that we're studying almost every combination you can imagine with bispecific antibodies, in particular teclistamab, as you've noted, whether it was with a proteasome inhibitor, with an immunomodulatory drug, with a CD38 antibody, those are being examined. I do think that the strong trend in the country has been to use the drug less frequently than the every weekly dosing that was originally in the clinical trials. I would say that most of us, after 12 to 16 weeks, especially in patients who've had a response, are dropping down to every other week. Some are even dropping down to once a month after 6 months. And then there's still a smaller fraction, but some who actually at a year and a half or so, depending on response, may even give some people off therapy. But there are studies now explicitly looking at that. Hopefully we'll know more. I am currently on Talvey, Sarah says.
So Joe, can I just make a quick comment about that? So, I'll tell you, we're dropping the dose within the first 2 cycles because patients are if they're going to respond, they're responding very quickly. And the M protein response usually lags behind the marrow. So if they had a VGPR, I have no issues with reducing the dose. And we're very quickly going to once a month dosing. And the real question is, do they even need that? So can you go to every other month or every third month? If you look at a T cell from a patient on a BCMA bispecific with monthly dosing, over 60% of the T cells are still bound with the antibody. And so you basically paralyze those cells, and you may actually, by giving less frequent dosing, increase the efficacy of the drug. We don't know that, but certainly I don't know that you're going to decrease it when you've got so many T cells bound with the antibody.
Gotcha. Excellent. Yeah, I mean, I think we need to learn a lot more about that. It goes back to what we said earlier. I mean, most of the drugs we're using, we've historically used probably a too frequent and too high a dose. So Sarah was asking the question that she's on Talvey. She's been on it for a year. Unfortunately, she's having side effects, and obviously we can't answer all the details of these kinds of questions. And we know you're in touch with your provider, but what am I going to be able to use after Talvey treatment? Well, a lot of the answer to that would depend on what's been treated with before. But one of the benefits of having Talvey as a different target or as a GPRC5D target is that we often can thereafter engage a different target like BCMA again. So that could be a consideration, Sarah, obviously to be discussed with your provider. Vincent asked a pretty complicated but important question. I'm sure, Sagar, you saw the recent paper coming from our friends in Iceland about the redefinition of the interval of light chain ratio normality in patients who were older with impaired renal function, going from the historical 0.26 to 1.65 that we've been using for several years, now suggesting that it could be broader from 0.44 to 2.16. And so the person is asking, well, if my light chain ratio is down at 0.19, so outside of that range, does that make that person's disease more worrisome?
Yeah, again, I think what changing the range did was reduce the number of MGUS consults that we would get from renal and rheumatology, who seem to have a stamp on what they do with every new consult that just generates business for us. I still think somebody who's outside that range, it comes down to reviewing all the other data. And the way that I think about it is actually Rafael Fonseca used to say that treating myeloma is like flying a plane. You don't use a single gauge to make a decision. You look at the whole picture. And if the M protein is really low and the hemoglobin and everything else are pretty stable, with a light chain at one time point of 0.19, I don't know that it changes necessarily what I'm going to do.
Agreed. David, you asked a question about Arcelix's announcement about anito-cel. We hopefully had a good discussion around it. I think we're all very excited about the results, both the depth of response and the lack of neurotoxicity, but we'll obviously need a little bit more time. Tim asked this question, Beth, and he says, I've been fighting myeloma for 14 years. I had CAR T-cell therapy in January of 2025. I'm struggling with fatigue and weakness. Do you feel this is normal, or is this my new norm?
So there's a couple things that happen after CAR T. So everybody talks about this delayed neurotoxicity, and I do see some fatigue, and I call it chemo brain type of neurotoxicity, where you have to write notes, etc. I tend to recommend a lot of exercise. It doesn't mean run a marathon. It means get up every hour and walk for at least a minute or two, and then gradually increase. Looking at your diet, meeting with functional medicine, and then there's some other things for cancer-related fatigue that haven't been studied in this population, but American ginseng has been used in the palliative population for cancer-related fatigue for years. And so I have some people that, again, it's not a study, I'm not recommending it, so don't go out and buy it, but some people find things like that and some other stimulants to be effective. So talk with your provider and talk about some of the side effects you're having. Make sure to optimize some of the vitamins and checking vitamin studies, et cetera, to make sure that they also don't have any vitamin deficiencies that can be corrected. And also thyroid is something we forget to look at as well.
Great, excellent. A great question from Lori. If you're on antibiotics, does it hurt your chemotherapy? Lori, obviously this has to be discussed with your provider as to which one you're on, but generally speaking, that has not been an issue for the vast majority of the antibiotics, and it's particularly the ones that you would be prescribed on chemotherapy. It really shouldn't have an impact. Sometimes if it affects your nausea or your stomach, that could have a minor impact, but it's really not of significance. There's a great question here from David Sagar, who asks, based on what was being done in Barcelona, where they had sort of make your own CAR T or made their own CAR T in the academic center, do you think this is going to be a part of the future? Do you think we're going to see more academic places, actually making CAR Ts?
Yeah, it's a really interesting idea, and our program had embarked down this road a few years ago, and unfortunately, the regulatory hurdles are a little bit more difficult now than they were a few years ago, and quite honestly, we're not sure where the FDA is going to go with all of these approvals. So you could get an approval for a new construct, and what the Barcelona group really did was provide access to Spain, which as a country didn't have access to a BCMA CAR T-cell, and they were able to manufacture it for less. It's not clear that that was necessarily any better than what we had that's out there already. But in Spain, you didn't have access to a commercial CAR T like we do in the US. So I think if there's a way to talk about reducing cost for a CAR, right now, a CAR is around $550,000. And the efficacy of the CAR is similar, then identifying ways to be able to make modifications on the fly and not have 12 and 18-month delays at the FDA, those are going to be the key pieces to really making quick advancements. But I don't know that we're ready there right now.
Excellent. And for time's sake, I mean, it just hurts my soul to see about 50, 60 more questions that we have not had a chance to get to. But let me again remind everyone that we really do want to answer your questions here at the IMF, and I'll do my utmost. We may, based on this, have to host an additional Facebook Live where I just answer these questions in rapid fashion because we don't want to leave people out. But please continue to submit them, and don't forget to submit them through any of our social media channels with the hashtag #AskTheIMF. I'll come to just our final slides here and remind people to please fill out the feedback survey. We'd love to hear about what your thoughts are about tonight. We would like to thank our sponsors again, AbbVie, Johnson & Johnson, Regeneron, and Sanofi. And I just want to take a moment to remind people of our vision at the IMF, which is a world where every myeloma patient can live life to the fullest, unburdened by the disease, as we seek to improve the quality of life of myeloma patients working towards prevention and a cure. And with that, I'm going to thank very much my dear friends and colleagues. You both mean a great deal to me personally and professionally. Sagar, Beth, thank you for all that you do for myeloma patients. Thank you for your expertise tonight. Is deeply appreciated. And for the audience, thank you so much for joining us. And please continue to interact with us. We'd love to help you in every way we can. Thanks, everybody, and have a great night.